I am a person first.
I am not disabled.
I have a disability.
I'm not stupid.
I'm not a big child.
I'm a person first.
I am a person.
I am a person.
Hello, I am Clement Kuziak, President of the International Association of Lions Clubs.
And I'm Timothy Shriver, Chairman and CEO of Special Olympics, an international movement providing Olympic-type sports, training, and competition for people with intellectual disabilities in more than 150 countries.
The relationship between Special Olympics and Lions Clubs International is one of the strongest social partnerships in the world. Our two organizations have joined forces to create the Opening Eyes program. This program provides quality vision screenings, eyewear, and appropriate referrals to Special Olympics athletes.
The driving force behind the creation of the Opening Eyes program was the realization that far too many people with intellectual disabilities simply do not get the high-quality health care they deserve. We came to understand this better as we analyzed the data from our Healthy Athletes program, and we discovered that a consistent problem was the lack of adequate educational preparation and practical experience for healthcare professionals. So this global curriculum is designed to provide that specialized training for vision care students and professionals in all types of practice settings that will enable them to meet the vision care needs of people with intellectual disabilities and provide them with the high-quality care they deserve.
We urge individual eye care professionals who have not had the opportunity for such training to take advantage of it. This curriculum will transform the way in which vision care professionals both view and treat people with intellectual disabilities. We hope this energizes you, your practice, your college, and your community in reaching out to better serve people with intellectual disabilities.
Once you take advantage of this information, please, we beg you to be sure to apply it. After all, knowledge without action means nothing to our athletes. We welcome you as a volunteer. We look forward to seeing you on our field of play, and we encourage you to become ambassadors and leaders in the work of providing high-quality opportunity for people with intellectual disabilities. Let them see. Let them get a chance.
Welcome to Opening Eyes to Intellectual Disability. Allow me to introduce myself and briefly outline what I expect will be a fascinating journey for all of you. We expect, at the very least, that it will transform you into better eye care professionals. Another positive outcome is the hope that you will become more sensitive, aware, and compassionate individuals. I promise you, you will not walk away from this course unaffected. I am Gordon Eilert, a member of a committee which came together to create a program to educate eye care professionals about the eye care needs of people with intellectual disabilities. The reason that we are bringing this intensely valuable and important information your way is because we have found that there is either a gross misunderstanding or sadly even no understanding of the intellectually disabled patient in many medical disciplines today. And I use the word patient because I speak in terms of getting medical attention, but they are people first, and as doctors we must learn to treat the person.
There is discrimination that exists in Zachary's life that we would never have imagined, whether it is preschool placement, whether it is friends, whether it is parents. And we have learned to deal with those discriminations, but what we can't afford is a discrimination when we look for medical services and we go to the doctors. We can't afford that. And we can navigate our way through the different forms of discriminations that we'll experience and that we have experienced, and we learn from them and we can move forward. But that being an obstacle when it comes to medical care, that is so critical because it sets us back 6 months, it sets us back 12 months, it sets us back 18 months, and those are months that we can't regain when it comes to his development. Yeah.
There you have it. These are real people with real medical issues who require real attention. The medical attention they need is no different to that of the average patient. The personal attention they need is vastly different. Different, not difficult, and it is truly one of the most rewarding experiences a doctor can have.
During the course of the last century, we all witnessed major improvements in health around the world. And while a range of countries continue to invest in improving the health of their individual populations, it is simply not realistic to speak in terms of improved healthcare without addressing those individuals with the greatest need, intellectually disabled people among them. The needs of this population have been overlooked for far too long. More than 30 years ago, December 20th, 1971, the General Assembly of the United Nations passed a resolution proclaiming the Declaration on the Rights of Mentally Retarded Persons. In the resolution are some irrefutable rights, not the least of which states people who are mentally retarded have the same rights as other human beings. This means they have the right to the same things we have all come to expect: economic security and decent standards of living, the right to live with their own family or in foster care, and access to participation in the community, a qualified guardian to protect their personal well-being, protection from abuse and exploitation, and proper medical care.
I can go back when I was a child. My mother took me to a doctor for my feet. The doctor looked at her and said, because she was poor, after we sat in the clinic hours upon hours, we used to take our lunch and I used to take my knitting. The doctor looked at her and said, you know what, these retarded kids dream. Take her home and just smack her in the butt. She wouldn't walk on the side of her feet. Doctors listen, people listen. It's a shame what our people are going through.
Many decades later, former US Surgeon General David Satcher witnessed the unmet health needs of mentally retarded people from around the world when he attended the World Winter Special Olympics Games in Alaska in 2001. He was so struck by what he observed there that within months he authored a report and then went on to write a second report on the issue of the health needs of persons with intellectual disability. In a message introducing that report, Secretary of Health and Human Services Tommy G. Thompson validated the flaws Surgeon General Satcher found with the system, adding, "Unfortunately, societal misunderstanding of mental retardation, even by many healthcare providers, contributes to the heavy burden. Too few providers receive adequate training in treating persons with mental retardation. Even providers with appropriate training find our current service system offers few incentives to ensure appropriate healthcare for children and adults with special needs."
After a while, the doctors providing them with medical screening or anyone dealing with them in any other way will gain a lot of experience that would lead those special individuals to communicate in an excellent manner with people around them and become beneficial to society.
So it is vital for everyone watching this DVD to understand that the goal of the curriculum is not to develop specialists in treating people with intellectual disability. Rather, it is felt that the mastery of the curriculum, combined with practical experience, will enable most providers to competently care for the majority of persons with intellectual disability. They are people like you and me, who have hopes, dreams, fears, loves, likes and dislikes. These are people who can accomplish amazing things when given a chance. It is important that society, beginning with us, tear down the barriers that prevent them from achieving their goals. This includes health and healthcare barriers. This includes you.
Individuals with ID are not different. You just have to give them, like every other patient, one-on-one personal care.
It is a more significant challenge, and I think that we need to expose students to these challenges because it will make them better eye care providers, not to mention better human beings.
What it's taught me is unconditional love of parents, and that you have to approach somebody in the style to which they need to be approached. You have to walk in the room and within 10-15 seconds know how to get the information you need from that child. And you're also just very empathetic and warm with the kids, and that's really taught me a lot.
I think it is probably the ultimate experience that any doctor, I think, can have, and that is knowing that being able to go the extra mile and working with a person with a disability means that you're going to impact that individual's life tenfold.
It's made me listen more. It's opened up my mind to all the other possibilities there are as far as what this person's needs are and what I can do to help them.
I've learned to be more patient, I've learned to be more caring, and I've learned to be at a level where I can talk to them on a one-to-one basis without feeling overwhelmed or scared or frightened.
Don't worry about being silly. Don't think that you're really hot stuff, and get down on the floor and play.
I have a lot of folks in my office with patients with intellectual disabilities, and it's the best part of the day. We play, we have a good time. It gets me out of the routine of how I deal with all these other patients, and it's challenging, but it's a tremendous amount of fun. And you can't come out of this type of experience and not think that you're making a contribution to someone's life.
How long have people with intellectual disability been around? About as long as the rest of us. Some of the earliest records discovered an age in Egyptian papyrus scrolls.
Since that time, people with ID have been perceived as objects of both fascination and fear,
resulting in them being both worshipped and vilified. From the earliest days and still today, such a perception leads to myth, stereotyping, discrimination, mistreatment, and ultimately denial of opportunity. Opportunities including suitable health care.
In many countries, it was common practice to advise parents to attempt no heroic measures to let the child live, or at the very least, institutionalize the child for his own good
and the good of his family. The life of an ID person was to many a life not worth living. An early myth holds that the birth of a child with a disability is a sign the parents or family had done something to offend the gods
or their god, and this child is retribution for their crime. Some consider the child a bad omen and shun the child's entire family, fearing personal misfortune. It is this kind of twisted thinking that to this day leads to slaughter or infant neglect in some societies.
In ancient societies, those judged less than perfect were thrown to their death from atop cliffs or worse, sold into slavery to be used at whim for entertainment and amusement. Finding the best way to address the needs of this population has also been around since the beginning
of time. During the Middle Ages, foundling homes are established to house individuals with disabilities, but infanticide, slavery, and abandonment continue.
Finally, in 19th century Europe, eTaught develops an extraordinary program to develop the emotions, social skills, and language skills of a foundling child. A comprehensive approach to educating children with intellectual disability follows.
Later, this revolutionary logic is brought to the United States, spearheading the American Association on the Mental Retardation. The die is cast, or so it is thought.
In England, as late as 1908, feeble-mindedness is determined, quote, largely inherited, and it is said that these people should be segregated from the rest of society. In the early 1900s, the United States begins introducing sterilization laws. By 1931,
sterilization is enacted in 27 states. These laws are upheld by Justice Oliver Wendell Holmes, who says, "It is better for all the world if, instead of waiting to execute degenerate offspring for crime, or to let them starve for their imbecility, society can prevent those who are manifestly unfit from continuing their kind." The principle that sustains compulsory vaccination is broad enough to cover cutting the fallopian tubes. 3 generations of imbeciles are enough.
And in Great Britain, the government legalizes the detention of, quote, idiots, imbeciles, feeble-minded persons, and moral defectives. And by 1929, up to 100,000 individuals with disabilities are institutionalized with segregation of the sexes
to prevent breeding. The policy of institutionalization continues unquestioned for many decades, with quality of care
and education varying greatly. Finally, in the U.S., toward the middle of the 20th century, advocacy groups are established, and it is determined that purely custodial care is no longer acceptable, that these individuals have a right to treatment. In 1975, the United States Congress passes what is now the Individuals with Disabilities Education Act.
In 1975, the United States Congress passes what is now the Individuals with Disabilities Education Act, finally providing appropriate education for children with mental retardation and developmental disabilities.
The US, Canada, Australia, and most of Western Europe have now adopted the integration of these individuals into the community, providing them greater social access and providing the public a long overdue education in the non-threatening nature of intellectual disabilities.
And while these breakthroughs offer this exceptional population a more rewarding, more normal existence, where, we're left to wonder, is the revolution in their access to suitable health care?
This is where you come in. For the majority of individuals with mild disabilities, communicating medical needs is fairly routine, and your treatment will be as well. Sometimes, though, they and their caregivers do run the risk of not understanding the significance of early signs and symptoms. So you should be aware that these people might present with more advanced disease than the general population. For more severely affected individuals, significant communication difficulties often do exist, making it incumbent on you as the eye care provider to actively look for common signs and symptoms of disease processes. They are identifiable syndromes associated with intellectual disabilities, thereby increasing the likelihood that these individuals will be suffering from certain diseases. You will be familiarized with the specific health concerns associated with different segments of the ID population later on in this curriculum.
While there are specific syndromes to focus on with intellectually disabled patients, it is vital for medical providers to understand that we're more the same than different. Often starting at the birth, an individual with a disability is identified by their deviation from normal. This characterization of being different or defective, though not entirely representative of this person as a whole, becomes the predominant label. Prejudicial judgments that a person with an intellectual disability will never need to drive a car, operate a computer, read, or care about social interaction can be detrimental to this person's future life and achievements. So it is not the differences in the patient with intellectual disability that should set the standards for approach to care. It is the similarities. As Dr. Robert Cook, medical consultant emeritus to Special Olympics, has stated, persons with intellectual disabilities need all the types of care that the average person needs, and they need some additional things too.
A recent in-depth study by Special Olympics of the attitudes of the public towards persons with intellectual disabilities shows a consistent belief that these individuals, regardless of their severity, are only capable of performing simple tasks. Further, a clear majority of the public across the world believes that this group will be disruptive in school and the workplace and will compromise safety, learning, and productivity. In other words, the majority of people surveyed think of the entire intellectually disabled population as more profoundly affected when in fact only 5% of people with intellectual disabilities are categorized as having severe or profound intellectual disabilities. Finally, a myth often perpetuated in the healthcare field is that people with intellectual disabilities do not feel pain, or they don't feel pain in the same way as others. And prevalent myths still persist that somehow healthcare may be wasted on persons with intellectual disabilities. Not only are these myths untrue and unjustified, they often lead to the belief that people with disabilities lead shorter lives, when in fact they can lead long and fulfilling lives if they get the necessary care and support that they require and deserve.
Intellectual disability occurs in all nations and within all cultures and is perceived differently around the world. Central to this disability is the notion of intellectual impairment. Within the ICF, which is the International Classification of Functioning, Disability, and Health, intellectual functions are general mental functions required to understand and constructively integrate the various mental functions, including all cognitive functions and their development over the lifespan. Mental retardation is included as a qualifying condition.
People with impairment of intellectual functioning also have related impairments, such as memory, attention, household work, preparing their meals, self-care, and other limitations that we take for granted in life. Within the ICF, the environment could either help you build your capabilities or actually impede.
The definitions of intellectual disability just vary all around the world, and generally the criterion that has been put together by the American Association on Mental Retardation in 1959 includes three commonalities. The first is significantly sub-average intelligence. This also follows substantial limitation in adaptive behavior, and the combination of the two generally manifests in the developmental period before the child or the individual reaches the age of 18.
The current AAMR definition is: mental retardation is a disability characterized by significant limitations both in intellectual functioning and in adaptive behavior, as expressed in conceptual, social, and practical adaptive skills. This disability originates before age 18 years. The determination or diagnosis of mental retardation assumes that the evaluations conducted were culturally and age-appropriate, recognize legitimate differences in language, behavior, and cultures, that strengths and limitations may coexist, that identification of limitations should be accompanied by a corresponding list of supports, and that limitations can be reduced over time through the provision of supports. This, and previous definitions offered by AAMR, are similar to, and have influenced, other widely used classification systems, such as the Diagnostic and Statistical Manual of Mental Disorders, 4th edition, DSM-4, the International Classification of Diseases, 9th revision, ICD-9, and the International Classification of Mental and Behavioural Disorders, 10th revision, ICD-10. Beginning in 1992, AAMR dropped its previous classification of severity of intellectual deficit, i.e. mild, moderate, severe, profound, and adopted a system for categorizing levels of supports needed: intermittent, limited, extensive, and pervasive. These are the percentage of people with mental retardation for each level of intelligence: mild, about 85% of those affected; moderate, about 10%; severe, 3 to 4%; profound, 1 to 2%. Despite the shift of AAMR from levels of intellectual deficiency to classification of supports, the levels of intellectual deficit are still widely used. A system also put forth by the WHO takes classification of severity out of the realm of assigned IQ scores, or numbers, an inherently difficult assignment to visualize, and assigns a more easily conceptualized mental age.
In this section of the curriculum, you will hear the term neurodevelopmental disorder. A neurodevelopmental disorder is the underlying biomedical cause of intellectual disability. Another way of stating this relationship is that intellectual disability is the common symptom that many people with different neurodevelopmental disorders exhibit. The first thing that must be in place before a clinician diagnoses and treats a patient with neurodevelopment disorders is a conceptual framework. And one of the first steps in building this conceptual framework is the establishment of a meaningful vocabulary and language rooted in the principles of physiology and medicine.
As previously mentioned, terms such as mental retardation, intellectual disability, learning disability have been used in general reference to patients with any number of different neurodevelopmental disorders. Terms such as maroon, idiot, or feeble-minded were in common usage, though our terminology has clearly evolved over the years to a higher level of social sensitivity. All these terms remain largely focused on a single, externally manifested, functionally symptom exhibited by a patient with an underlying neurodevelopmental disorder.
Though useful in some context, these terms only describe one characteristic of this patient population, the one of intellectual disability. Unfortunately, it doesn't provide complete scientific information to the clinician who's in charge of clinical evaluation and management of the patient.
The major functions of the brain include memory and learning, control of motor function, processing of sensory input, and emotional regulation or control. These functions require that specific interrelated brain structures work together in a coordinated fashion. When these relationships develop improperly or are disrupted, dysfunction results. We can categorize these disorders as either biological or neurodevelopmental.
By definition, a neurodevelopmental disorder is a medical disorder that must affect the neurological system during the period of a person's life in which they are experiencing rapid neurological development, from the point of conception to early adulthood.
For many patients with intellectual disabilities, the specific neurodevelopmental disorder has not been established, and in many cases has not been pursued. As advancements in genetics, biochemistry, and lab testing develop, this number of people with undiagnosed causes will probably decrease. A proper diagnosis, however, is helpful in determining an effective treatment plan and should therefore be pursued by the clinician with all reasonable effort.
Neurodevelopmental disorders can be either genetic or acquired. Genetic causes may be metabolic, chromosomal, or structural, whereas acquired etiologies may develop as a function of a more external event, such as trauma or infection, and will occur prenatally, perinatally, or postnatally. Some genetic examples of neurodevelopmental disorders are chromosomal, Fragile X, Down syndrome, Prader-Willi, structural, tuberous sclerosis, neurofibromatosis, Sturge-Weber syndrome, Marfan syndrome. Metabolic, phenylketonuria, metachromatic leukodystrophy, and examples of acquired neurodevelopmental disorders include acquired, may occur prenatally, perinatally, postnatally. Infection, rubella, toxoplasmosis, syphilis, toxic insult, fetal alcohol syndrome, kernicterus, lead toxicity, trauma, structural damage, cerebral palsy, neoplasms. Every neurodevelopmental disorder will have one or more complications due to the disorder. These complications fall within a few large categories. They include impairment of cognitive processing, as in intellectual disability, impairment of sensation, as in blindness or deafness, psychiatric illness, as in schizophrenia or chronic depression, impairment of physical movement, as in spasticity, rigidity, or other neuromotor dysfunctions, seizures, abnormal impulse behavior.
Each complication of a neurodevelopmental disorder may carry with it secondary health consequences. For example, intellectual disability and sensory impairment may increase chances of traumatic accidental injury. Psychiatric illness may lead to poor hygiene and self-neglect. Impairment of physical movement may lead to osteoporosis. Seizures may lead to bone fracture or aspiration. And abnormal impulse behavior may lead to self-injury.
So from a medical standpoint, intellectual disability is a complication of an underlying neurodevelopment disorder. It's very important to ascertain the underlying diagnosis, and what I mean by that is the neural development disorder, so that a complete picture of the patient's health, complications of their functioning and their health consequences, and their complications too, are accurately diagnosed, so that one has a better predictive value of the increased concurrence of the additional syndromes and specific conditions related to this individual.
Examples of syndrome-specific conditions include mitral valve defects, cataracts, and Alzheimer's disease with trisomy 21, albinism and tegretol toxicity with Angelman's syndrome, hypertension with Williams syndrome, and renal tumors with tuberous sclerosis. Clinicians should familiarize themselves with the related syndrome-specific conditions whenever possible.
One of the most important recent trends for people with intellectual disabilities is the trend of increased life expectancy. In 1929, in the United States, the average life expectancy for a person with trisomy 21 was 9 years. In 1990, it was 55 years. Now these patients are living well into their 60s. With this trend has come a greater focus on adult health care and aging issues for this population.
In general, people with intellectual disability age at the same rate as the general population, and therefore will experience the same range of age-related conditions. Problems in the area of psychological functioning, mobility, hearing, vision, cardiovascular, and gastrointestinal function will appear within the same relative time frame as the normal population. However, certain syndromes and genetic disorders may predispose a person to an increased rate of aging, and therefore, these health-related issues appear earlier within their lifespan.
Other syndromes may be complicated by severe or complex medical conditions, which also predispose certain anatomical systems to an increased rate of age-related deterioration. Psychiatric disorders occur with greater frequency than with the general population, but are often underdiagnosed.
With regard to specific syndromes, if a diagnosis is made, the clinician should familiarize him or herself with the syndrome's specific associated conditions, those unique to that patient's diagnosis. For example, it is well documented that people with trisomy 21 or Down syndrome age at an accelerated rate, and therefore in their mid-30s may experience medical conditions more common in elderly or patients over 65.
Because of this, clinicians should begin to suspect age-related complications in their patients with trisomy 21 earlier than for other patients in the general population. On autopsy, older patients with trisomy 21 show the plaques and tangles that are associated with Alzheimer's dementia.
Additionally, with people with trisomy 21 are likely to develop auditory problems due to recurrent ear infections. They may develop sleep apnea, hypothyroidism, dental problems such as periodontal diseases, and also they're more likely to develop significant refractive errors, cataracts, and a much higher risk of developing strabismus and nystagmus.
Patients who are medically complex, such as those with cerebral palsy, may also develop aging-related complications at a rate faster than normal. Conditions such as immobility and spasticity lead to an accelerated loss of bone density. This may be further accelerated by the use of seizure medications. Poor muscle control and laxity lead to greater acceleration of muscle deterioration, leading to an increased risk of falls and aspiration. Paraplegia may increase the risk and rate with aging of urinary infections, incontinence, and constipation.
When evaluating complex chronic medical issues, one should be aware that these conditions may cause the affected bodily systems to decline at an accelerated rate.
first thing we must do as medical professionals is to relate with the person, not the patient. And there's nothing daunting about it. Quite simply, when an individual with ID enters your office, introduce yourself, offer to shake hands, talk directly to the individual, not to the caretaker. The caretaker will be listening and interject when necessary. There's always a level of uncertainty in these situations, and each one must be evaluated individually. There's something the ID community jokingly refers to as the 10 Commandments of communicating with a person with disabilities. It's common courtesy regarding how to treat patients with disabilities when they come to visit you.
Speak to me, not my mom. Shake my hand, run with me.
Identify yourself when you're meeting a person who is blind.
If you offer to help me, wait until I say yes.
Treat adults as adults.
Don't lean or hang over to somebody's wheelchair.
Listen carefully to people who have trouble speaking and let them finish.
Talk to a person at eye level with a person in a wheelchair.
Tap a person who is deaf on the shoulder.
Relax. Don't be embarrassed. It doesn't matter what you say to us.
Example of an exam form that can be used to document findings on a patient with an intellectual disability. You'll be seeing how to use this form throughout the exam section. Please refer to the appendix to obtain the complete form.
This is a typical case history form. Become familiar with it. If at all possible, a questionnaire such as this may be sent to the parents or guardian of the patient well in advance, before the scheduled appointment. The advantage of this procedure is that caregivers can refer to records kept relating to the medical and/or ocular history of the patient.
The visual examination of the patient with intellectual disability can vary greatly. Most of the patients will not need any modifications to the exam procedures. Some patients, however, will require the clinician to modify the techniques and the organization of their exam. The strategy is to use your clinical judgment to determine the highest level of testing possible without frustrating the patient and still obtaining valid and reliable data. The case history should provide you, the clinician, with an impression of the patient's communication style, their comprehension level, and their willingness to participate in the activities. The examination should be directed towards identifying the cause of the patient's chief complaint or complaints, but at the same time providing a complete assessment of their eye health and their visual function.
It is also imperative to be aware of the patient's behaviour during the exam. Some patients fatigue or frustrate easily, and this may be evident with a reduced level of cooperation and/or resistance to cooperate. It's sometimes necessary to take a break or reschedule the appointment for another day. If the clinician has difficulty reading these signs, ask the person who accompanies the patient to the exam for assistance. The parent or caregiver may have better insights into the patient's behavioural responses. Keep in mind that sometimes the patient needs more encouragement to respond. Don't give up trying.
Observations.
Never underestimate the power of observation. This is especially true with this patient population. Observations will greatly supplement your case history by either confirming or denying reports of possible signs and symptoms. Like any clinical skill, with practice, the clinician will become better and better at making observations that will give meaningful information regarding the patient about to be examined.
There are several but obvious questions to consider.
Does the patient appear visually directed? Does the patient orientate to visual stimuli, to sound? Is the patient active and engaged in his or her environment? Is the patient making eye contact? Does the patient have an observable vision problem like strabismus, ptosis, nystagmus, abnormal head posture, like a head turn or head tilt? Can the patient communicate verbally, non-verbally? Where is it now, Tommy? Where's the stripes? Can you see the stripes? Very good. What is the patient's mobility like? Does the patient appear independent? What is the patient's affect? Is the patient able to manipulate objects? Do they have good hand-eye coordination?
Okay, you want to look at me? Look over here, Sarah. What I like to do first is just take a good hard look at the patient. And now I'm looking at Sarah, and if you look at Sarah, one of the things you notice is that her eyes are tearing. So first you want to look at, obviously, at the eyes, and we see tearing. Look over here, Sarah. Look over here. Okay, so she has tearing a little bit more on the left than the right. And then you also are looking at for things like a head tilt. We also see some discharge in the corners of her eyes. And then we'll certainly take a look and we'll see that she has some inflammation there. So we're going to want to see what we want to do about that. But we want to take a look at that. We also want to see if she has any visual directed activity. So let's see if she had what her eye-hand coordination is. Grab my finger. Good job. Take my finger. Come on, you can get it. Oh, good job. Are you a good girl? Are you a good girl? Da, 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 da. Are you a good girl? Yeah. Also, you notice what I'm trying to do is establish some rapport with Sarah, so when I start shutting off the lights and shining lights in her eyes, that she feels a little bit more comfortable.
The patient's general physical appearance should be noted, including alertness, overall size, weight, body type, and interactions with others as well as objects in the environment. The head size and shape and facial features should be evaluated.
Visual acuity, visual function. It is important to be able to quantify how well the patient can see. Visual acuity measurement is the primary measure that eye care practitioners use to accomplish this task. The goal is to be able to use a well-accepted, standardized measure that can be interpreted by all eye care practitioners around the world. The purpose of visual acuity measurement is to identify if acuity is normal and equal between the eyes. Visual acuity can be measured directly, as with a Snellen test, or an estimation can be made by making observations and evaluating refractive error and alignment. The measurement of functional visual acuity can help the clinician rule out pathological conditions that may cause reduced acuity. Reduced acuity may signal a significant refractive error, amblyopia, ocular or systemic conditions, or it may reflect the inability of the patient to comprehend or even communicate what response is expected. The key to accurately assessing visual acuity is to choose a technique that the patient will be able to complete with a high level of validity and reliability. Of course, knowing the patient's developmental and cognitive level and communication style will assist the clinician in selecting the most appropriate test. The patient must have an understanding of what is expected of them, as well as the ability to express themselves. It's also important to keep in mind that visual acuity assessment requires the ability to maintain attention for an extended period of time. Because of this, it is necessary to work quickly, and you may need to take breaks, do something else, and then return to the visual acuity testing later in the exam. It's also beneficial to decrease the test distance used, moving from the standard 6-metre test distance up to 3 metres perhaps, or even closer. This helps improve attention. However, any adjustment to the protocol needs to be documented because, of course, effective visual acuity level changes with a change in the working distance. Visual acuity is one of the most important elements of the exam, so be sure to take time to maximise the patient's response. If interest is fading and the patient is fatiguing, try to end on a good note and return to the test later in the examination process. It is suggested that the clinician begin testing with the highest level of acuity assessment that it is thought that their patient can complete. Test designs that utilise familiar symbols as the optotype are preferred if the patient does not know the alphabet well enough to rely on Snellen visual acuity. Visual acuity testing that allows the patient to match the shapes of letters will enable the clinician to obtain a visual acuity measurement on most patients. Patients who are unable to name or match shapes or letters we'll need a test that utilises a forced choice response, such as the teller or Cardiff acuity cards, or fixation preference testing. These tests require minimal communication, since the patient demonstrates that he or she can see the target by looking towards or pointing to the stimulus that represents a particular visual acuity level. The most important information to obtain is monocular distance visual acuity, followed by assessing binocular near acuity. Some patients may not allow you to cover one eye for various reasons. In cases where the patient is resistant, attempt a less intrusive means of occlusion by trying occlusion glasses with one of the lenses covered with tape. Some patients are threatened by occlusion of any kind, and this may make monocular testing unobtainable. In these cases, binocular vision may have to suffice. In cases where monocular acuity measures are impossible, be sure to rule out potential causes of reduced monocular visual acuity by performing a careful cover test, refraction, and ocular health assessment. If these other measures are normal, it is unlikely that amblyopia would be present. Lastly, many clinicians begin the examination process by measuring visual acuity. However, when working with individuals with intellectual disabilities, you may consider beginning the exam with tests that are objective and therefore do not require a response from the patient. If the patient's anxious about the exam, it may be difficult for them to perform in the very beginning, but they may warm up later on in the examination process. There are many methods commercially available to use. The purpose of this program is to highlight the most commonly utilised tools. However, this does not suggest that other techniques are less valid measures. The program will present a testing methodology that may offer more successful visual acuity attainment, which can be applied to other commercially available techniques.
Identification, recognition.
This is the highest level and the most sensitive type of acuity measure, and will be the most likely to identify if reduced vision exists, which may be caused by pathology or physiological degradation. This type of acuity requires that the patient be able to identify a form or its orientation. Targets are localized and decrease in size with finer levels of acuity. Visual acuity charts may present single stimuli in isolation or charts in which multiple stimuli are presented together. The preferred method is a full chart with multiple stimuli because it allows for contour interaction from nearby stimuli, which is known to affect recognition acuity. Tests that utilize a single isolated optotypes tend to overestimate the visual acuity. Using a test that has linear format or symbols surrounded by each other or with contour interaction bars is the preferred method of testing. The following are popular and accessible visual acuity tests.
Mark, could you help me here, please? If you take this paddle and actually cover Billy's left eye for me over his glass.
Visual acuities are based on a log-Mars scale, as recommended by the National Research Committee on Vision,
Okay, Billy,
1979.
let's have you go ahead and read this one right on top here for me.
Apple.
The chart is calibrated for use at a 10-foot, 3-meter test distance.
Square.
Very nice. And we'll go this side. How about this one?
Square.
This one on the top?
Circle.
Good. This one?
Square.
Right
Apple.
here.
The patient identifies or matches the symbol on each line: circle, heart, square, or house.
Good job. How about this itty bitty one here?
Circle.
Can you tell me this one right here?
House.
Good. How about this one?
An advantage of this test is that the symbols blur out equally when the stimuli are smaller than the patient's resolution ability. The symbols all look the same below threshold.
Square.
Good. How about this one?
Apple.
Good.
Cards are available with single stimuli on a single card, with crowding or a linear format so contour interaction is constant. Make sure the patient is familiar with the symbols, or at least consistent with what they are naming it or matching it to similar symbols. For example, the circle may be called a ball, and this is acceptable as long as the patient consistently calls the circle a ball.
Let's have you tell me this one.
Apple.
Mm-hmm.
House.
Good.
Square. House.
Good.
The acuity level is determined by the lowest line where 3 of the 5 symbols are recognized correctly.
Circle.
Good.
All right, Billy, I'm going to have you take your glasses off for me.
Hold my glass for me.
Oh,
Right,
there we
thank you,
go.
Mark, you're a genius, man.
Actually, here, let me help you put this patch on your eye.
All right,
Thank you.
me.
And we need his glasses again. Thank you. Here we go. Go ahead and put these glasses back on for me.
I'm Elvis.
We're going to do the same test for near, okay? We're going to get some lighting here so you can see well.
A matching near visual acuity test is available.
All right, I'm going to have you actually hold this bead. First, it's going to tell me, go ahead and keep looking straight right here. Go ahead and hold this bead with your hand. So that'll tell you exactly where you need to be and not move forward from there, okay? What I want you to do is go ahead and tell me what this one's right on top.
Apple.
It is sometimes easier to begin testing at near than to test in the distance. Having a matching near card is beneficial since the clinician has already taught the patient how to do the test in the distance.
Here. Don't come forward. Go ahead and hold this right here. There we go. It'll tell you not to come forward. Go ahead and read that.
Oh.
This one right here.
Circle.
Good. How about the next one?
Apple.
Good. The next
Circle.
one. Very nice. Right, let me take this from you. Go ahead and take your glasses off. Very good.
Leah symbols are the closest symbol test to the gold standard of visual acuity testing. General procedures for acuity determination. There are some general guidelines for determining visual acuity with recognition testing. The clinician should first establish whether the patient is familiar with the objects on the acuity chart by reviewing the symbols or letters before testing. If not familiar with them, provide a name for each symbol or teach the patient to match the pictures with a handheld chart. Once you're certain that the patient can respond to the targets, proceed to monocular testing by occluding one eye. You can use an adhesive patch, pirate patch, patient's hand, or caregiver's hand, or occlusion glasses. It is generally not recommended that the patient hold the occluder. When examining small children, the clinician's hand, fingers, or thumb may be sufficient and less intrusive for those patients who refuse the occluder or patch. The testing procedure should move as quickly as possible. Begin testing by pointing to the first symbol on each line of the acuity card in descending order. Continue down the chart until the patient incorrectly identifies a symbol. Once an error is made, move back up to the previous line and ask the patient to identify all of the symbols on the line. If the patient was able to read 75% of the symbols correctly, move to the next line down. If not, move up to larger targets until 75% accuracy is obtained. Testing continues until the patient gets less than 75% or 3 out of the 4 symbols correct. According to the visual acuity measurement standard, a line of optotypes is generally considered to have been read correctly when more than 50%, e.g. 2/3, 3/4, 3/5 of the optotypes presented have been read correctly. Resolution.
Threshold on these tests represents the smallest angular separation that can be detected between neighboring targets. The targets use equally fine detail over a large area. The overall size of the target stays the same, while the gratings decrease in size. Preferential looking is known to overestimate visual acuity, and it can actually miss strabismic amblyopia and foveal anomalies since the target is so large. Communication is based on looking responses instead of naming or matching, so it's easy to perform.
Beepo, where are you? That's good. Okay. And let's try one of these other cards. Not going to be very useful with that one.
If you don't mind me saying, Tommy will react a little bit better if you just get a little more personal with him,
Right.
be a little more friendly with him.
Yeah, sure.
Christopher, Tommy's brother, is suggesting to the clinician that a more personal, less clinical approach might help reach Tommy.
Tommy, can you look at me now? Can you look at me? And that's good job. Really good. Excellent. Let's have a look now. The teller acuity cards are a forced choice preferential looking test designed with one side of the card containing square wave gratings or black and white bars, with the other side of the card presenting a blank target with matched luminance. Fantastic. Just pop those up a bit higher. You're doing really well. Good man. And let's try again. You ready? See if you can tell me where the stripes are this time. Ready? Shall we see that?
Begin testing with a card, with the demonstration card, and say to the patient, "Look," or point at the stripes. If an appropriate response was seen, move to actual testing, continuing to smaller gratings until random responses are seen.
And where are the stripes now? Well done. I'd say they're on the left. Good. Excellent.
Too close.
Let's do another one now. You ready? Let's see if we can jumble it up so we don't know where they are. You ready? Oops.
The cards are presented at eye level to the patient. The examiner looks through the peephole in the center of the card and observes which side of the card the patient's eye moves toward. The examiner should be aware as to which side of the card contains stimulus or bars. A positive response is determined if the examiner saw the patient look toward the side of the card with the grading patterns. The visual acuity levels are read in cycles per degree and are based on the Logmar measures and are not directly comparable to Snellen. The cards can be used at one of three test distances: 38 centimeters, 55 centimeters, or 84 centimeters, with acuity levels equivalents listed for each distance. The 38 centimeter test distance was designed for 1 to 6 month old infants. The 55 centimeter is the test distance for most pediatric patients, and the 84 centimeter test distance was designed for adults with intellectual disabilities. Just a tip: the length of the cards are 55 centimeters.
Where are the stripes?
The test design is based on the premise that most individuals will look towards novel targets rather than a blank field. If the bar gratings are at a level that the patient can resolve, they would be expected to look to that side. Once the gratings are so fine that they fall below visual acuity threshold, random eye movements can be seen. If the sides appear different to the patient, then the patient will look toward the bars. The cards can be presented left, right, or up-down. Use the peephole in center to observe responses. Prevent bias by not being aware of which side the bars are on until a firm decision as to where the patient is looking can be made.
Shall we see if we can do this? Can you see the stripes now? Can you see them? No? They've disappeared. Let's try again. Ready? Let's try really hard.
If the patient has nystagmus making it difficult to view lateral eye movements, present the card vertically. The presence of lateral strabismus or congenital ocular motor apraxia may also require the vertical presentation.
Gonna look at me? Tommy?
No. You know, we could be sitting anywhere. It's just
Tommy?
You're doing good, Tom.
You're doing good.
You're going, Tom. Do you know where this is?
Make sure that when presenting the cards that sufficient light falls on the front surface.
Are they too small?
The visual acuity level is smallest grading, at which at least 3 out of 4 correct responses were seen. A significant finding is if the interlocular difference is greater than or equal to 2 cards. This suggests that you closely evaluate the eye with the poorer acuity and rule out any refractive causes, strabismus, amblyopia, or pathology that may be causing this difference.
Can you see the stripes? You gonna look at? Very good. Very, very good.
Detection.
So what we're going to do first, can you see this? Can you see this? What's this? Is this a dinosaur? Can you see the dinosaur? Keep looking at the dinosaur.
Detection acuity testing tends to overestimate visual acuity and are only used when recognition or resolution techniques are unsuccessful. Oftentimes, objects for testing are items that the patients are familiar with and has been known to respond to. Things that have been used, food items, lights, and ribbons. The clinician can use observation of the response to the targets by observing whether the patient can fixate and follow the target while looking for central and steady fixation, and is able to maintain it for a short period of time. To do this, place the target in front of the patient and observe the patient's ability to fixate and follow the target as you move the target to elicit a pursuit eye movement or head tracking. Look also at the ability to maintain fixation on a non-moving target or light. This can be done monocularly to compare the right eye to the left eye. The technique does not equate to good visual acuity, and the inability for the patient to pick up fixation may mean any number of things, including poor acuity, poor attention, or an ocular motor anomaly. While examining patients who are unable or unwilling to fixate on any object, rely on the power of observation. Watch patients' behavior. Note if there's any difference in the resistance to occlusion, as well as attempt to see if the blink reflex is intact.
That's good. Well done.
Binocular vision testing.
Peter, what I'm going to have you do now is look at Bert across the room. And while you're looking at Bert, I'm going to be covering your eyes, okay? Are you ready? Keep your eyes wide open so I can see them. Okay, watch Bert, not me. Take a look. Look at Bert. Okay, keep looking at Bert, not at me. I know I'm more interesting, but look at Bert. Keep looking. Okay, same thing. I'm going to do the other eye now. I want you to watch out. Watch Bert. Don't look at anybody else. There we go. You're looking at me. Where's Bert? Where's Bert? Are you looking at Bert? Look at Bert. Let's use something a little bit larger, something that'll hold your interest a little better, okay? Let's find a target that I don't think Bert's captivating enough. Peter, is that a little easier for you to see now, all those characters? Okay, each one of those characters is different. Can you look at the polar bear? Where's the bear? The big white bear? Can you watch him? Watch him closely. Look at him. Keep looking. Look at the bear, not at me. Keep looking. Where's the bear? There you go. Okay, good work. Now look at, what do we have out there? Do you see the gray bear? Look at him. Keep looking. Excellent. Okay, now what I'm going to do is I'm going to put something in front of your eyes. Are you ready? And then I'm going to move the paddle from one eye to the other. You have to keep looking at that gray bear for me. Can you do that? Okay. Watch closely. Let's put it out there. Let's see. Let's keep looking at the gray bear. I need you looking out there. Okay, let's go a little higher. Let's try up here. You got to keep your eyes wide open for me. No, look out at the bear, not at me. Great. Nice work, Peter. Keep looking out there. You got to hold your eyes on that bear. Okay. What we want to do is get a reversal, and I'm not getting a reversal because his fixation's a little bit hard to keep. It's hard to look at those guys? Yeah, I know. You know what we're going to do is we're going to try it up close so it'll be easier for you. Okay. Let's try it. You know your letters pretty well, right? What letter is this? E. That's an E. Perfect. What I'm going to have you do is look at the E. Okay, let's try it without your glasses first, and I think we'll be able to see your eyes a little bit easier with this. Are you ready? Are you ready? Okay, you want to touch the E to make sure you can see it? Touch it for me. Perfect. Okay, watch the E for me. Look at the E, not at my paddle. Sometimes it's easier if the paddle is distracting to use your hand. Look at the E for me. Look at the red ball with the E. Keep looking. Super. Excellent. Hold your eye on that E. Keep looking at it. Nice work. Excellent. There's the E. Look at the E. Find it. That's perfect. There you go. Look at the E. The E. There you go. Where's the E? Nice work. Do you think you can help me now? I'm going to have you hold the E. Okay? And when you look at the E, I am going to take and cover your eye with my hand again, just like I did before. Okay, are you ready? Let's try it this way. Okay. Okay, look at the E. Where's the E? Look at the E. Look at the E. You're not looking at the E. I see you looking at me. Okay, put your hand out here. You're doing great. Okay. Look at the E. Oh, actually, that's pretty good. Let's see if we can get a reversal. Let's go up a little higher. You ready? Okay. Is that hard to do? I know, but you're doing a great job. I need your arm out here. Look at the E for me. You see it? Look at the E. There we go. Good work. Actually, perfect. We got a reversal. Nice job. You want to try with your glasses on? Yeah, it's a lot easier to do it with your glasses on. Okay. Beautiful.
Modification of cover testing for young children.
We'd like to give you some suggestions to modify your cover test, especially when the patient has limited attention span. One of the first things we found is that the occluder itself may actually be a distraction to the patient. So instead of using the occluder, what we'll suggest is you use your hand either this way or drop your hand down, or your thumb in much younger or smaller patients. Patients do get habituated to targets, so it's often good to have several targets that you think that the patient may attend to and change them periodically. Patients who have a limited attention span do have difficulty looking at things far away. So what we find that when we add sound to the task or having somebody across the room talking to the patient about the target, it helps to hold their attention on the target. If you use a target that has a light on it, turn the light on and off. That will oftentimes help the patient hold their attention on the target. In addition, if you're holding a target and you hold it still for a long period of time, often the patients will lose interest in that target. So move it around a little bit to gather their attention again. With patients who have a latent strabismus or actually a large angle strabismus, it may take them a little longer to pick up fixation. So when you cover their eye, allow them a little bit more time to bring the eye to the point of fixation. One of the things we find very challenging is when you want to neutralize the angle, having your hands available to use. So what we suggest is actually using a colorful sticker on your nose to hold their attention, and you can talk about it while you're there, giving your hands the opportunity to hold the occluder in one and the prisms in the other. Flexibility and creativity are the names of the game. Brian, we're going to do something where all you have to do is look right at my light, and I'm going to look at how the light falls on the front of your eyes. Excellent. Because right here I see the light right in the center of the pupil, and that one's just a little bit off. Now I want you to keep looking at the light, and I'm going to cover one eye. Can you look right in the center of that light? Perfect. We're going to do the same thing with the other eye. Can you do the same thing? Keep your eyes really big like you saw a surprise. Perfect. Okay. That's it.
The Hirschberg test is a test of binocular alignment. It is performed at approximately 50 centimeters. Shine the light at the bridge of the patient's nose while observing the position of the light that falls on the cornea in each eye under binocular viewing conditions. This evaluates and measures ocular alignment. When the light falls on the center of the pupil, it is designated 0. A corneal reflex positioned nasal to the center is designated as a positive number and is measured in millimeters and is the distance from the center to where the reflex is located.
Hold this prism up in front of you and see what we can do. Look.
The Krimsky reflex prism test follows the Hirschberg and Kappa test. The patient binocularly views the light while the clinician adds prism over the more centered eye until the light reflex on the deviated eye becomes centered.
That was super. You could give lessons on that, young lady.
And with the beam set on the largest circle.
The last in the sequence is the Bruckner test. Here the examiner holds the direct ophthalmoscope with no power dialed in at 1 meter. Both eyes of the patient are illuminated at the same time, and the patient looks directly at the ophthalmoscope light. The clinician then compares the brightness of each fundus reflex. A whiter and brighter reflex in one eye suggests the presence of strabismus. False positives may be seen in infants between 2 and 8 months. This is an example of how to record presence or absence of strabismus.
And I'd like you to continue looking at my flashlight while I hold these prisms up over your eyes. I can hold it, that's okay. Thanks for helping, though. And I can shift the prisms up and down. Are you seeing double now when I hold the prisms up?
Yeah, doubles.
See if you can make it single. See if you can bring it together so it's just one.
It's still double. It's single now.
Single now?
Yes.
Keep watching.
It's double.
Double? Okay, how about now?
It's single.
Very good. Let's try it on the other side. Single?
Yes, single.
Single?
Yes, single.
Tell me when it gets double.
Single. Double a little bit.
A little bit double? How about now?
It's double between the lens. Okay. It's in the middle. The middle is single.
Good. Very good. That was great.
I have a target and it has a little number on it. You see my number 5? I want you to look at my number 5. And what I'm going to do is I'm going to have you follow my number 5 in until it gets close to your nose. Are you ready? Keep looking. Keep looking. Excellent. Look at the number 5. Keep looking. Oh, let's bring it back a little bit. Let's get it. Okay. You got it? Keep looking at the number 5. Super. Kind of hard. Okay, you're doing very good. Let's try it again out here. Okay. Wonderful.
Stereopsis.
The clinician should first attempt random dot stereopsis because it confirms alignment. Random dot stereopsis does not have any monocular clues and if seen indicates bifoveal fixation and therefore rules out constant strabismus. Lateral disparity demands a higher level of perceptual and cognitive skills than random dot stereopsis forms. When testing random dot stereopsis, you're asking the patient what they see. With lateral disparity stereopsis, you are asking them to look at an array of pictures and tell you which is perceptually closer to them. For all random dot stereo tests, suppression and diplopia will result in none of the random dot stereo forms less than 250 seconds of arc being seen.
To begin testing, present the Polaroid glasses in a fun way or ask the parent or caregiver, or you, to put them on first. Remember to have the patient keep their glasses on. If the patient demonstrates suppression, none of the random dot stereo forms will be seen. The random dot E is simple to administer, is designed as a forced choice test, and only requires the ability to match. The goal of the test is to differentiate the plate with the letter E from the card with the stereo blank in a forced choice task. Testing is done at 40 centimeters. First, present the demonstration plate that everyone sees along with the stereo blank plate. If the patient understands the task, substitute the demonstration card with the hidden E. To be successful, they must locate the correct target 4 out of 4 times, or at least 5 out of 6 times. Keep in mind as you change the test distance, you alter the stereo acuity level. For example, as you move away from the patient, the stereopsis gets finer, meaning the number gets smaller.
Okay, very good. Okay, Brian, we're going to do a test, and I'm going to ask you to put these glasses on.
Okay.
That's so you can look like a movie star, right?
Yeah.
Okay. In this test, I'm going to ask you to find some pictures, and the pictures are these things. What is that?
An example of a combination lateral and random dot test is shown. The first step is to review the pictures with the patient. Testing is done with the Polaroid lenses on.
That's okay.
I'm screwed up.
And what is that?
Down.
And what's that?
Plus.
Perfect. Okay, let's go to these pictures.
Ask them to match or name the figures. Start testing with the random dot section. See if the patient can find the pictures that are hidden. Next, refer to the box with the R and L to see if either eye is being suppressed as evidenced by one letter missing.
Now up here, I have circles. It's the same thing as the animals. One of those is closer to you. Which one is closer? The one on this side, the middle, or on that side?
In the middle.
Okay.
Lastly, proceed to the lateral disparity section and ask the patient which animal is closer or which ring. Move from the larger disparities to finer levels. 40 seconds is the expected norm.
We're going to go to another test. It's just like this, where you are going to look at pictures, but the difference is we don't need to use the glasses. Okay?
Oh, okay.
What I'm going to do is hold
The Lang Stereo Test 1 is used when you are unable to get the patient to wear the polarized glasses since they are not needed. You need to present the test plate at the patient's eye level. Since movement of the target does provide for some perception of the figures, it is critical to hold the test still.
It's right here.
Okay. Do you see a kitty cat there?
Carefully observe the patient to gaze towards a picture or touch a picture hidden on the card. Identification or localization of at least 2 pictures to succeed on this test.
Hold on, I'm thinking, I'm looking.
Good, good looking. You see it? You might not see it, it's okay. If you don't see it, tell me.
Oh, it's around this area.
Around that area? Okay, very good.
Would you like to wear these funny glasses? Let's make you into a movie star. Ready? Yeah. No, you're going to put them on. Go on, please.
It's okay.
You try them on. Should we just try? You have a look through. Here we are. You look through this way.
Actually, put them on me.
Here we are. Let's put them on Christopher.
Tommy, watch.
Let's put them on Christopher.
Watch. See?
There we are, Christopher.
See?
It's no problem, is it?
Do you want me to put them on you now? Okay.
There we are. Let's see if Christopher can put them on.
It's all good. Oh, it's
Well
okay.
done. That's good.
The Randot stereo smile test is designed for patients who do not have reliable verbal or matching skills. The test does require the use of Polaroid glasses to view the stereoscopic stimulus, which is a simple smiley face. Like the teller acuity cards, the response is a forced choice. The test contains a non-stereo demonstration card, which can be seen by everyone.
Shall we show you? Look, can you see this face? Can you see that? Yeah? Can you see this face? Yeah? That's good. Let's see if we can do that again. Ready? Where's the face now? Good. Excellent. Where is it now? Excellent. Really good. And shall we see if we can see it with this one?
The clinician observes which direction the patient views as the cards are presented. Did the patient move their eyes to the stimulus or just demonstrate random eye movement? Testing is performed at 55 centimeters. It is important to watch the patient at all times, since it is not uncommon for them to purposely avoid looking at the target.
Can you see the face there? Very good. Very good. You've done really, really well. Let's take these glasses off, shall we?
The refractive assessment most often begins with distance retinoscopy. In an effort to control accommodation, videotapes or animated toys with sound, light, or music can be set at the far end of the exam room. This is more significant for your patients less than 40 years of age.
I want you nice and comfortable. You just lean your forehead forward. Let me just get it all set up so it's perfect for you. I'm just going to change.
Using phoropters or trial frames can sometimes prove difficult with people with intellectual impairment. The clinician cannot maintain eye contact to ensure the patient is looking into the distance. However, one should not make any assumptions, just as with acuity testing. Use the appropriate method for the individual patient.
You just keep your eyes open and keep looking far away for me. Very good. Keep looking. I need you to keep concentrating. Nice work.
Can you see that cat over there? Can you see the cat?
If the phoropter and trial frame are unsuccessful, lens bars or even handheld lenses, this allows the clinician to move with the patient for proper alignment. You can also watch their pupils. If you see them constrict, they are accommodating.
Can you see the cat again? Very good.
Can I take these funny things off?
Just 2 seconds and we'll be all done. If you look at that cat again now, because they're a bit heavy, aren't they? You look at the cat.
Yeah.
Have you got it? Where is it? You look at it. That's brilliant. Well done. Excellent.
Autorefraction is useful as a screener in the office or for confirmation of refractive errors, especially for high refractive errors. It is not reliable enough to be used by itself under non-cycloplegic conditions. It is most reliable when patient is cyclopleged. Both desktop and handheld models are available. When doing autorefraction, encourage the patient to look at the target. Consider performing this prior to retinoscopy to get an estimate of refractive error, especially cylinder axis. This will provide a good starting point. Don't forget to look at reliability number to determine usefulness of information. Discard the readings if the reliability is too poor.
Can I see big eyes like you saw a surprise? Oh, big surprise. Look. There we go. Very good. Oops.
Nice job.
Guidelines for difficult refractions.
If the retinoscope reflex is difficult to interpret, for instance if there is a scissors motion present, try to focus on the central portion of the reflex, as the peripheral portion can be confusing and distorted due to spherical aberration and coma. With motion is always easier to interpret than against motion. Add minus lenses until with motion is easily seen, reduce until definite against motion is seen, and then bracket inwards until neutrality can be determined. Move towards or away from the patient to verify changes in reflex. If no reflex is seen with retinoscopy, check for media opacities with your ophthalmoscope. If a red reflex is present, notice the amount of plus or minus in your direct ophthalmoscope to clear the retina. Scope with high amounts of plus and minus in maybe 5 diopter increments to 20 diopters or more if necessary until a red reflex is seen. Adequate fixation of the patient is sometimes difficult to achieve, so ask the parent or caregiver to sit across the room and attempt to keep the patient's interest. Possibly attempt a cycloplegic refraction. If the retinoscope reflex seems to keep changing, there may be accommodative fluctuations or off-axis scoping may be occurring. Cycloplegic refraction may be indicated. Mohindra retinoscopy is good to use when you cannot control distance fixation. The setup calls for a completely darkened room, so dark that the only thing the patient can see is the light from the retinoscope. Use a dim light on your retinoscope so that it is not a strong stimulus for accommodation. A working distance of 50 centimeters is used. One of the patient's eyes is occluded and the other fixates the dim retinoscope light. This eliminates the accommodation induced from accommodative convergence. Subtract 1.25 diopters from your gross findings. Cycloplegic retinoscopy, if this is available, can be used to confirm refractive error. Use if fluctuating responses, poor fixation control, or if there is an ESO deviation, amblyopia, significant astigmatism, or anisometropia is present.
Tips for drop installation.
Never lie to the patient and tell them they won't feel a thing, but equally don't make a big deal about how it will sting. The best method is always the one where you can get the drops in the eyes as fast as possible.
Cool.
Some clinicians tell patients that drops feel like swimming pool water, or that they are flavoured and have the patient guess the flavour once the drops are placed in the eye, or some tell the patient that they will feel the drops until they count to 20. These last two techniques get the patient to concentrate on something other than the drop in their eyes. The best way, of course, to avoid discomfort is to use anaesthetic. However, the anaesthetic itself stings, and that may be the last drop you'll get to place in their eyes. A lot of clinicians have had great success with cycloplegic spray, and if you see children or patients with intellectual impairment on a regular basis, you should consider investing in a bottle. For full cycloplegia, use 2 drops of cyclopentolate spaced 5 minutes apart, 1% for children greater than 1 year old and 0.5% if they're under a year. Add tropicamide and or phenylephrine for patients with dark irides, since cyclopentolate is not a great dilating agent. Mydriasis is not a good indicator of when full cycloplegia has taken effect. Therefore, look at the retinoscopy reflex. If variability or changes in brightness occur, either add another drop or wait a little bit longer.
Keratometry is an important supplement to your refractive assessment in the presence of significant corneal astigmatism.
Ocular motility testing is very informational. When you first meet the patient, look at them, watch for anomalous head position or eye movements as the patient enters the room. Is the patient able to maintain eye contact and have stable fixation? Look for the presence of nystagmus and changes as the position of the eyes change. If nystagmus is present, attempt to identify which gazes cause nystagmus to increase and decrease, the null point. Next, do version testing by asking the patient to follow your target, moving in an H pattern. Use a pen light or finger puppet to hold their attention. It may be necessary to hold the patient's head to isolate eye movements or elicit doll's head movements by having the patient fixate on the clinician's face, while moving the head into each action field, while the patient maintains fixation on the clinician's face. As the patient's eyes move to each of the cardinal positions, look for the ability to maintain fixation, move smoothly, and note if there is a limitation in any gaze or the presence of nystagmus or change in the pattern.
Try not to move your head.
If nystagmus is present, note if the nystagmus is acute, as in an emergency situation, or chronic, which would be congenital in nature, Which fields of gaze does it increase? Does it decrease with convergence or in a particular gaze, a null point? Is it present under monocular, latent nystagmus, and/or binocular conditions? Does it increase with fixation? Is the oscillation large or small, or amplitude? Is it jerky, fast or slow phase, or pendular, moving back and forth in nature? Cover each eye to conduct duction or monocular testing in the same H pattern as done with versions. Watch the lid position to assist in noting if a restriction is present. After versions and ductions are assessed, look at the quality of pursuits and saccades. You are primarily checking to see if these eye movements are present and how efficient they are, specifically looking for gross undershoots or overshoots with saccades or excessive head movement with saccadic and pursuit eye movements.
Excellent.
Several modifications can be made to ocular motility testing of patients. In order to increase the patient's attention and accuracy of fixation, use targets that are age-appropriate and familiar. Try to have several targets available in case the patient becomes bored with the first target. In order to isolate the eye movements from head movements, it may be necessary to hold the patient's head or have the caregiver hold their head. Some clinicians like to use a light under a finger puppet in order to increase attention to the target. You may wish to flash the light intermittently. If you are looking for the presence of nystagmus while doing direct ophthalmoscopy, monitor any movement of the optic nerve.
Accommodation.
Dynamic retinoscopy, or MEM, is a commonly used technique to assess accommodative posture during near-point tasks in young patients. In this technique, the patient fixates targets attached to the front plane of the retinoscope. The target should be age-appropriate. Use a reading level at least 1 year below their reading level or pictures when the patient is illiterate or preliterate. Set the retinoscope at the patient's habitual near working distance. Quickly dip the trial lens in and out before the patient accommodates. A lag greater than 1 diopters is abnormal and may suggest prescribing a near-point ad, along with the patient's age and lifestyle evaluation. Patients with diagnosed motor impairments will often present with a high lag and benefit from lenses designed for near-point to compensate. MEM is also used to confirm the best prescription for astigmatism and anisometropia. Testing of color vision is important because the prevalence of congenital red-green color deficiencies occur in approximately 8% in males and slightly less than 0.5% in females. That equates to 1 in 12 males and 1 in 200 females. The Ishihara pseudo-isochromatic is the most accepted standard screening test, but is not always successful. One method to increase testability is to give the patient a cotton-tipped applicator and ask them to trace the numbers. The color vision test, Made Easy test, is also a pseudo-isochromatic test, but uses common shapes. For example, circle, square, and star instead of numbers. The patient is to locate the circle on the demonstration card and the 9 test plates. One of the limitations is mild deuterans may pass the test. When classic norm tests are not successful, it is suggested that the patient is asked to color name or match various primary colors. This task is language-based or perceptual in nature and is appropriate for developmental ages of 3 to 4 years. This is qualitative and not an acceptable indicator for color vision tests.
Systemic aspects and external appearance.
Critically observe the patient at every opportunity.
Rest your forehead right against that white band. That's perfect.
The external structures of the eye can be assessed in a number of ways. The least invasive and probably the least sophisticated is simply taking a pen light or transilluminator and a 20D condensing lens and illuminating the anterior section of the eye and yielding a general assessment of lids, lashes, conjunctiva, iris, and anterior chamber angle. However, in order to obtain a thorough assessment of the structures, a stand slit lamp is the primary tool. It allows the patient to be held in position by the chin rest and forehead stand.
That's great. Now lean forward, look down to the floor. Super.
No matter which instrument is used, be sure to check for the integrity of the lids, lashes, sclera, iris color and appearance, vasculature, cornea, AC, and lens.
We're almost done. Great, nice job. You can sit back. Your eyes look very healthy.
Okay, Jessica, what we're going to do now, we're going to have a look at your eyes with this one, which is, again, it's got a light in here. And this is so I can have a close look at the front of your eye. Is that okay? Yeah. So I'm going to come up quite close to you. Good girl.
In your evaluation, identify if there are any pupillary anomalies, ptosis, or lid anomalies, or orbital anomalies. Be sure to palpate the orbital region to detect masses.
Can you look up to the sky? That's good. Good girl.
Remember to check the lacrimal drainage system, which may be impaired in patients with Down syndrome.
Very good. Excellent. That's very good indeed. So I'm just going to pop a little bit of this in your eye. Okay, can I slip your glasses off again? And this doesn't hurt one bit, I promise. Okay? What I want you to do, look up to the sky for me. Look right up to the ceiling.
Okay, okay.
Well done. That's all done. Can I pop some in the other eye? Yeah, it wasn't so bad, was it? Look up again. Did I get any in? Can I pop a little bit more in?
The Burton lamp can be used in conjunction with or without fluorescein to evaluate the anterior structures of the eye.
Now, just going to have a look at your eye with this lamp. There we are.
Since the Burton lamp does have cobalt blue lighting, it can be used to rule out the presence of a corneal abrasion or foreign body.
Sorry, my eye.
Internal health.
Direct ophthalmoscopy is a valuable tool in this patient population. It provides a less intimidating environment than other tools that are used to assess the internal structures of the eye.
Forward. And look back again towards the toys, and I can show you where the toys are again one more time. Remember those toys back there?
Yeah.
I'd like you to watch those toys. Hold your head real straight. Watch the toys while you're leaning forward. And I'm going to look in the eye. Just keep watching the toys. That's very good. It's excellent. Very good.
Indirect ophthalmoscopy is the standard of care in many areas. If using a binocular indirect ophthalmoscope, you can use the doll's head movement to get the patient into each gaze, especially if you're having a hard time directing them into each gaze. Another technique to assist with fixation control is to use a bright and noisy peripheral target to direct the patient into each field of gaze. Use the lowest illumination that allows adequate viewing of the eye. The advantages of the bio include: it is easier to detect nystagmus due to the increased illumination and magnification and close working distance, and quick views are better than long views if the patient is having a difficult time with this procedure. An alternative to the bio, which is not always well tolerated, is the monocular indirect ophthalmoscopy panoptic. These provide a larger viewing field than direct ophthalmoscopy and is preferred if you are unable to dilate the patient's eyes. If inadequate views are obtained with direct or indirect ophthalmoscopy, or you suspect pathology, you can order evaluation under general anesthesia. Another tool available when indicated to check the posterior segment behind an opacity is a B-scan ultrasound.
Pupils.
You're seeing well with your glasses?
Yeah.
Good, good. I'd like you to look down at the end of the room. Do you see the toys down there? Watch this.
Yeah.
Okay.
Yeah, the toys.
That's where I'd like you to look down there while I'm testing your eyes.
Okay.
And I'm going to shine some flashlights in.
Okay.
You can watch the toys while I shine the flashlight.
Testing pupillary responses is the identical to the testing you would perform on all other patients. Begin testing by reducing the overhead illumination to allow for a maximum dilation of the pupils initially. Your pupillary assessment should include both a direct light and swinging flashlight test.
Hi Tim, what we're going to be doing now is we're going to be measuring what we call your pupils. The pupils is a little center of your eye which is black. They get bigger and smaller when the light shines in it.
You need to routinely attempt to check for relative afferent pupillary defect as permitted by the patient. It is imperative that you ensure that the patient is fixating on a distance target to reduce the accommodative response seen in viewing near targets. Keep in mind that patients are certain medication may present with sluggish responses, and in younger patients who are overstimulated, responses may be reduced.
Super.
Intraocular pressure.
Hi, Tim. I just want you to hold this tissue for me. I'm going to be putting some drops in your eyes.
All right.
Okay? And this drops is going to enable me to measure the pressure in your eye.
Okay, doctor.
Okay, just put your chin back. Okay, blink your eyes a little bit. If you need to, you could pat your eye. Don't rub it, though. Make sure you just pat it gently. Perfect. That's good, okay? Now I'm just cleaning this off. And we're going to have to make you a little bit lower, Tim, because I'm going to need you to get your chin right in here.
All right.
Okay? Okay, Tim, I need you to put your chin right here.
Goldman tonometry is the current gold standard in the measurement of intraocular pressure.
And this is going to get really, really close to your eye, okay? But keep your eye...
Most patients with intellectual disabilities will understand and be able to comply with this form of testing. It is best to complete this when using the stand slit lamp.
Stay nice and open. You are a great patient. And perfect. That's great. And the pressure in your eye is good.
Okay.
That's a good thing.
Good.
Okay?
There are some patients who are resistant to placing their head in the lamp or refuse to comply. In these cases, the tonopen is the next best alternative. It is a form of applanation tonometry and correlates well with golden tonometry. The primary benefit to this instrument is that it is a handheld instrument which yields reliable readings. Readings at a 5% level are preferred. The first step is to instill anesthetic drops in each eye.
Here we go.
Be very careful not to hyperextend the neck of a patient with Down syndrome when instilling drops.
Do you know what that is? It's a numbing drop, and it makes your eye feel like it's just kind of floating out there. What do you think?
Better.
I think you were very brave. Tell you what, I'm going to chill out just a tiny bit on the light. And let's see, this thing gets really close, but you have to help me count the clicks. Here we go. Now I have to have 2 stripes on it first. We got 2 stripes, so I guess we're ready to work.
Ready the instrument by obtaining the double lines on the screen and touch the cornea until the beeps are heard that indicate that the readings are complete. Keep in mind that latex probe covers are used, so be aware of any latex allergies.
Thinking about it hurt, huh? I bet we can do this, you and me. Shall we try it? I'm going to lose my double stripe here in 2 seconds.
There are patients who are resistant to this type of testing since the instrument does touch the cornea. If you feel you have made an effort and are unsuccessful, you need to use alternative methods.
Now, we can't decide if that's a wolf or a dog. What do you think? What do you think, Elizabeth?
He looks like a husky to me.
It could be.
Which is part wolf.
Right? But don't huskies usually have 2 different colored eyes?
Look at the man and do.
I'm not sure we're going to get this data, but we will try because a glaucoma check is really important to get.
It's hard.
If your eyes numb, I'm not.
Liz,
one more time.
This is all there is.
Tell you what.
Okay?
Oh, I have another thing we could do. I'm going to get rid of the wolf. And can you hold your hand up and look right at your thumb? Now, I'm going to get in front of this eye.
If a non-contact tonometer is not available, proceed to digital pressure. Touch the orbit with your index and middle fingers over closed lids. Record your interpretation as soft, medium, or hard. This is not considered an accurate quantification of IOP, and if it is imperative to obtain an accurate IOP assessment, sedated examination or testing under anesthetic may be indicated.
I think you're doing a great job.
Thanks.
Visual fields.
And we were going to do a confrontational visual field too. This is a test of your side vision.
Yeah.
And so this test is a little harder. It requires a little concentration.
Right.
What I'd like you to do is take your left hand and cover your left eye with your hand like that. So we'll test just one eye at a time.
Okay.
And while you're looking at my nose, I'd like you to
Right.
keep your eye right on my nose.
Right.
I'm going to show you some fingers in both hands.
Yeah.
And you tell me how many fingers I'm showing.
Confrontation fields are appropriate to assess in these patients. In addition to the typical testing procedure that Dr. Mills is demonstrating, you can modify the procedure by changing the stimuli from fingers to a toy, transilluminator, or a finger puppet. Have the examiner's face or a noise-making toy act as a central target, and use a larger toy or hand puppet for peripheral awareness. Look for a fixation shift, or have the patient point to the target.
1.
It's hard, isn't it?
Yeah. 2.
Good.
Examination sequence.
When working with patients who have intellectual disabilities, there may be limits to both the quantity and quality of the data that can be collected. In order to get the most and best quality of information you can, you need to eliminate distractions and improve the patient's attention by increasing his or her interest in what you're doing. Place more emphasis on objective tests. Minimize subjective tests. Test and target selection depends on the patient's developmental level. This is very important to know from the start. Knowing this can avoid frustration to the patient as well as the clinician. Use the highest level assessment procedure possible. Be prepared to change your testing methods and be flexible. Have a friendly environment. This includes you, your staff, as well as your office environment. Have age-appropriate entertainment in the waiting room like books, toys, videos, and possibly even invest in a small TV with a video player for your exam room. Keep in mind the developmental level and individual preference, as not all patients with intellectual disabilities will like children's toys, games and video. Obtaining an accurate case history is the foundation of any examination process. A good case history allows the clinician to determine a list of tentative diagnoses and possible treatment options. When making a diagnosis, astute clinicians should always relate the findings back to the patient's entering complaint. When examining individuals with intellectual disabilities, obtaining an informative and accurate case history can be challenging, but not impossible. Clinicians that take the time to make the patient feel at ease will be in a better position to gather meaningful information. This starts by building a relationship with the patient. The relationship must be built on loyalty and trust. Patients must trust their clinician, and the clinician must prove himself or herself worthy of that trust by serving the interests of the patient. The clinician-patient relationship is fundamental to the successful taking of the medical history, performance of the physical examination, establishment of the diagnosis, writing of the treatment plan, and the acceptance of and compliance with that treatment plan. If a patient with a disability manifests significant intellectual disability as a complication of the disorder, a clinician's fidelity and faithfulness to the interests of the patient will be tested. In some cases where there is cognitive impairment, it may become necessary to bring a third party into the decision-making process and, therefore, into the clinician-patient relationship. The introduction of this third person increases the likelihood that someone's, other than the patient's, interests will be attended to. In these situations, the clinician must strive to be ever vigilant and protective of the patient's interests. The involvement of a third person, no matter how well-intentioned and supportive, increases the complexity of the entire patient care process.
If a patient is capable of making his or her own legal decisions, he or she should be included in the decision-making process. If the patient is unable to make an independent decision and has a representative, sometimes referred to as a legal guardian, who is responsible for making his or her decisions, the guardian and the patient, to the greatest extent that it is possible to include the patient in a meaningful way, should be included in making decisions. It is imperative that the clinician makes certain that the person giving consent for the patient is, in fact, the patient's legal representative, and that this fact is well documented. It is equally important that the clinician be mindful of the fact that he or she has a responsibility to see to it that treatment decisions made on behalf of the patient with intellectual disability are made by an individual who is fully capable of giving informed consent. Informed consent typically means that 1. the treatment plan has been explained to the patient in language the patient understands. 2. The risks and benefits of treatment have been explained in language the patient understands. 3. The risks and benefits of not receiving treatment have been explained in language the patient understands. 4. The patient has been given the opportunity to ask questions and have his or her questions answered in language he or she understands. And 5. The patient gives consent after the information has been presented in an understandable manner. If the patient is not able to provide consent, they still need to give assent or willingness to participate. In some urgent or emergent situations, it may be necessary for the clinician to proceed with the medical treatment, even though informed consent cannot be immediately obtained. This should only occur in situations in which withholding treatment presents an immediate health risk to the patient. If the risk to the patient is not immediate, thorough steps to obtain informed consent from the patient or the patient's representative should be taken prior to treatment or examination.
Worldwide, there are various laws relating to discriminating against people with disabilities. Practitioners should obviously endeavour to offer the same level of service to everybody, whatever their level of ability, but should also be aware of specific laws relating to disability discrimination in their own country or state. The moment the clinician enters the clinic and begins interacting with the non-communicative, intellectually disabled patient, the clinician-patient relationship will be tested. The intellectual disability may render the patient unable to vocalise or localise a complaint or problem. This inability to voice a chief complaint or provide any subjective information that might shed light on the early diagnostic process increases the diagnostic challenge, but may not preclude the ability to make a diagnosis. It is critical to remember, however, that the patient's intellectual disability in no way diminishes the clinician's responsibility to the patient. The clinician has the same responsibility to this patient as to the patient in full possession of his or her intellectual faculties. The responsibility to take a complete chief complaint and medical history, to thoroughly examine, to accurately diagnose, and to effectively treat remains unchanged.
This is a typical case history form. Become familiar with it. If at all possible, a questionnaire such as this may be sent to the parents or guardian of the patient well in advance, before the scheduled appointment. The advantage of this procedure is that caregivers can refer to records kept relating to the medical and/or ocular history of the patient.
In any patient population, effective clinical management requires the establishment of an accurate diagnosis. And in the clinical management of this patient population, it is of vital importance that the process be orderly, thoughtful, and unhurried. As previously mentioned in the discussion on informed consent, decisions regarding the extent to which the cognitively impaired patient can and should be involved in the treatment plan decision-making are decisions which must involve legal considerations, some objective measure of cognitive skills, as well as common sense. It is also important that the clinician assess the patient or guardian's ability to comply with any treatment option. In doing so, the clinician must be mindful of such issues as finances, transportation, guardian's time, and the patient's ability to communicate. As patients with intellectual disabilities age, the age and age-related health concerns of the guardian should also be taken into account. If the caregiver begins to develop sensory, motor, or intellectual disabilities associated with age, treatment plan compliance for the patient could be dramatically affected.
When making a diagnosis, don't be intimidated by the complexity of the case. Work through it one step at a time. There's no need to solve all the problems on the first visit. Keep the chief complaint in mind. Remember to maximize the patient's visual needs for their daily activities. Treatment always works better when you use a family-focused management strategy. Support the patient and involve the family and caregivers. The most important part of the examination is to simply communicate to the family and the patient their visual capabilities. It's important to understand that uncertainty comes from two sources: The quality of the data, which is affected by the level of cooperation and accuracy of communication and sensitivity of the techniques used. And the quantity of data, which is affected by inability to respond to testing and may yield insufficient information to support the decision-making process. You can increase the quality and quantity of data to decrease uncertainty and maximize your input. Increase the quality by allowing the patient extra time to respond. Consider pre-examination preparation by the care provider. Pick tests that are appropriate for the level of development of the patient. Use alternative tests, Leah symbols instead of Snellen. Modify traditional tests. Use matching instead of naming when measuring visual acuity. Finally, optimize your knowledge base in this area. Learn as much as possible about the patient. Understanding the patient's condition will help you formulate management plans that are relevant to the patient's visual and personal needs. And you can improve the quantity of data. Be flexible. Remember priority and variety. Make the patient comfortable, behaviorally as well as physically. Use caregivers to aid in gathering information on visual function and health. Use an incremental approach. Gather parts of the examination over multiple visits. And to decrease uncertainty, you must consider all the available management alternatives. Many benefit from glasses with improved ability to identify people or objects, improved eye contact, improved sports performance, improved posture when performing near tasks, and improved fine motor and gross motor skills development.